Hello, good evening. This is Dr. Joel Friedman. I'm a psychologist with CFG Health Systems, and I'll be talking with you today about the intersection of the criminal justice system and individuals with mental health treatment needs. I am a psychologist by training. I'm hoping that some of you have read my bio. I don't really need to review that. And I want to talk with you about both the history of how people with mental health needs have become involved or connected with the criminal justice system and changes over time that have led to a great increase in both the number of people who are incarcerated in general and the number of people who are incarcerated with mental health treatment needs. At this point, I am going to start maybe sharing my screen with you. So if that works, great. If you're not able to see the PowerPoint, I do apologize. But let me start with sharing my screen. So the intersection of criminal justice system and individuals with mental health treatment needs. A large component of this began in the 1950s when there was a development and use of antipsychotic medications, which began to take place on a more common basis than it had ever before. The hope offered with these medications was that people who had previously been kept in psychiatric hospitals, often for stays as long as several decades, could be treated effectively outside of a hospital setting. So the hope was one of improved freedom, improved function in the community, perhaps better relationships with families, lack of separation from families. And the idea was to take people who, with diagnoses such as schizophrenia, would normally have been hospitalized for severely long periods of time with oftentimes no chance of being released into the community, have them treated and live and work in the outside world, outside of the psychiatric hospitals. At the time when these medications were developed, there was, like I said, great hope that this would lead to people functioning and fitting into society in a way that previously folks with those diagnoses had not. In response to this, once we started seeing the promise of these new medications, the Community Mental Health Centers Act of 1963 was enacted, and that was to provide federal funding for the community mental health centers, as well as to provide funding for research facilities and research in how we could treat people with mental health conditions in the outside world and how these medications would help them to both function, reduce their symptoms, and live hopefully more satisfying lives. There was a lot of promise around this, and there were a lot of great expectations that this would change the way people with mental health treatment needs would not just function day to day, but the course of their life would be improved. However, the plan was to establish many of these mental health centers and that they'd be seen by the National Institute of Mental Health, and there would be federal funding for them. There would be a place for people to go to get all of their treatment. Presentation mode. And if you can, hold on one second. Okay, and so the plan was for people to be able to, like I said, function in this way. And with the great promise of this also came great understanding of the treatment needs went beyond just having community mental health centers. A lot of states who saw that the funding for these community mental health centers was being promised believed that they could save money by closing their psychiatric hospitals, by referring people from the community mental health centers, to the community mental health centers instead of providing long-term hospital level care. And this led to people perhaps having beliefs that we would revolutionize the way we treat people with mental health conditions. While this was a wonderful and promising development, the reality fell far short of what actually took place. The reality was that people who had these treatment needs needed more than just outpatient care. Many of them had a lot of needs for things like social services, vocational training, things that were not necessarily funded in concert with the Mental Health Centers Act. And so we had many people who previously would have been, although it was a restriction in their freedom, cared for in a hospital setting. Now they were in the community without the same level of care. And while they had greater autonomy in some ways, they were lacking the support they needed to function effectively. And many of them ended up not just floundering, but becoming homeless or having significant problems in treatment because they may not have been compliant. And as most of you probably know, the medications, while they provided relief for some symptoms, also came with the cost of side effects, of difficulty with compliance, of limited effectiveness for some people. So while there was hope that people would function and do well in the community, the reality was a lot of them struggled and suffered. And so they went from a population that perhaps was unfairly hospitalized for great periods of time to a population that had a lot of treatment and social support needs not being met. Since the states had reduced the number of beds available in psychiatric hospitals, what happened was people didn't know where to turn, families didn't know where to turn. And a lot of people who previously would have been cared for in these hospitals now found themselves struggling with economic needs. Some of them lapsed into substance use disorder problems. And a lot of these community mental health centers, aside from not being fully funded, were just never built. And many of them that were built had staffing levels that were different in terms of professional training than you might have found in psychiatric hospitals. And so there were the shortages of mental health care. There were shortages in lots of the kind of ancillary treatment that people would need. And the number of beds that were available to people with mental health treatment needs back in the 50s and 60s peaked at over 500,000. That number has been reduced by about 90%. Different estimates will give you different figures for how many psychiatric beds are available now, but it is usually somewhere around 50,000 bed level when people do an estimate of this. So many people who had places to live before no longer had these places to live. And this set the stage for a large number of people with mental health treatment needs who now were not functioning well and fell into either the street life or substance use disorder. And they were now vulnerable to things that happened in their lives that put them in contact with the criminal justice system. And so we saw this large change, this sea change, if you will, of how we were approaching mental health treatment. There were advances, there were certainly things that were helpful, but there were risks that went along with those advances. And some of those risks, as they started to occur over time, led to not just people with treatment needs, but all these social services needs. And states that formerly kept them congregated in one place and at least identified and perhaps tracked more closely, now saw them spread out in the community in several different ways, oftentimes with little or no services. And a lot of the ways of both tracking and finding them for providing assistance was now much more difficult. A lot of those services, like I said, the occupational training, housing assistance, social and family support services were not sufficiently developed. And to this day, I think it's pretty fair to say that a lot of people who struggle with maintaining employment, who struggle with maintaining housing, find it very difficult to get full support. And this is where we find that people who struggle with these kinds of shortages of services often would have previously ended up perhaps in a psychiatric hospital, now end up in other places. And as I'll talk about in a moment, a lot of them came into contact with law enforcement, ultimately with the criminal justice system, and became incarcerated. A lot of times, what happens when someone doesn't fit the mold of what people are comfortable with in society, there is a very anxious and fearful response, and response to many people that look like perhaps they weren't fitting in or weren't functioning the way people would like them to function. The first line of defense was calling the police. Police were not really trained to deal with people that were experiencing crises or had severe mental health problems. And a lot of the funding that became available through the federal agencies that support National Institute of Mental Health was no longer given the same way. So now the community mental health centers were even more strapped because they had to apply for these block grants. And that made funding the services that were available even more difficult. And as people didn't get both the mental health services and the ancillary services and became in contact with a lot of law enforcement officials, primarily police, they became known in their community as people that were either difficult or were seen as dangerous or unpredictable. And they became labeled as folks that needed to be dealt with by incapacitating them, incarcerating them, keeping them off the streets, keeping them from making people feel uncomfortable. And so, as this first wave, this first social policy initiative, development of antipsychotic medication with the hope that people would be what they called deinstitutionalized, no longer be kept in an institution for long periods of time, as that first wave started to build and a lot of people were becoming in need of services, there was a great movement towards becoming tough on crime, having longer sentences, having the federal government get involved with what used to be more local law enforcement initiatives. And so we had a large population that was now at risk for what happened with criminal justice initiatives. So in the 1950s, like I said earlier, there were over 500,000 individuals who were in psychiatric hospitals. Many of them, unfortunately, stayed for very long periods of time, and the treatment was really not sufficient, and many people didn't necessarily improve. The term warehousing was often used, and some of the conditions were deplorable. So there was a downside to that that was clearly true. However, once there was a shortage of these beds, what followed was not necessarily an improvement, but just a change. Now we have, depending on the estimates, less than 10% of those available psychiatric hospital beds. And so the people who were incarcerated with mental illness started to occur because now people were either homeless or having difficulty supporting themselves, and they started ending up in our county jails and our state prisons and to some degree our federal prisons. And if you look at the correlation, it is striking that the number of people who are incarcerated with severe mental illness is estimated to be over 1 million at any given point in time. And if you look at the people that go through, sometimes on a revolving door basis, maybe multiple admissions to local jails, go through the criminal justice system each year and have severe mental health or at least significant mental health needs, that number is approximately 2 million people per year. So although at any given time it might be over 1 million, maybe as high as 1.2 million people who are incarcerated who have significant mental health problems, over the course of the year, many people go through that cycle. And when they're released, they're often vulnerable to being reincarcerated because they haven't received the care they need. A lot of facilities, county jails, state prisons, were built with the idea of incapacitation and security in mind, not with the idea of treatment in mind. And I'll talk a little bit about that when I talk about conditions in jails and prisons. Because people with mental health treatment needs often have difficulty adjusting to incarceration, they often end up with longer sentences, whether they're county jail or state sentences, than individuals without mental health treatment needs for the same types of offenses, the same types of arrests or convictions. There have been multiple studies that have shown that people with the same exact charges, those with and those without mental health diagnoses, tend to be incarcerated for different lengths of time. And once you have multiple incarcerations on your record, and once you have a documented history of difficulty with employment and difficulty with being incarcerated and difficulty with finding adequate housing, a lot of the social services become more difficult to obtain. And so you see this revolving door phenomenon that's happened throughout our country and has led to many people for long stretches of time going through that vicious cycle of incarceration, insufficient treatment, release into the community, either homelessness or difficulty finding adequate housing, difficulty with employment, substance use disorder problems, and then back to incarceration. We, in some ways, there was a term that was used called trans-institutionalization, that if you look at the number of people who were incarcerated in the 50s and 60s, it was relatively low compared to the number of people we incarcerate now. If you look at the number of people in psychiatric hospitals, it was much higher in the 50s and 60s than it is now. It's almost as if they migrated from being held in psychiatric hospitals to being held in correctional facilities. Thus, the term transinstitutionalization was used to describe not being removed from an institution, but transferring from one type of hospitalization or institutional setting to another type of institutional setting. The pathway may not be a direct correlation between people that had some problems in the 50s and 60s and people that are incarcerated now, but the numbers and the process by which people have switched from one place where they're held to another place kind of fits with what happened to people who were not able to get the care they needed. So, along with the movement to get tough on crime, there was the war on drugs. It's been a phrase that's been used to describe government initiatives to curtail the manufacturing, distribution, possession, and use of drugs that were deemed to be illegal. And in 1970, President Nixon enacted the Controlled Substances Act, which outlined 5 schedules of drugs. And Schedule 1 drugs were deemed to be the most dangerous. They were deemed to have little to no important medical value. And so the emphasis on fighting what was seen as a war on drugs was not so much on treatment as it was on eradicating this drug use and this drug community and this drug selling industry. And the emphasis was on treating it like a war, taking prisoners and putting them in places where they could no longer do anything that was seen as dangerous to the community. Some of the Schedule 1 drugs, it made sense that they perhaps were seen that way. Some of them perhaps weren't as dangerous as they were deemed to be, but nonetheless, it was something where people now could get very lengthy sentences for involvement in drug sale, manufacturing, distribution, use. And part of what happened with the war on drugs was, along with the Get Tough on Crime laws, a lot of the sentences became very inflexible. Judges no longer had discretion as to the minimum sentence they could give. And a lot of people who were involved in these drug convictions were sometimes part of larger organizations, even if they unknowingly were so. So you had what were called conspiracy convictions, where if you were caught selling a small amount of drugs, but the person from whom you purchased it, and then you consequently sold it, the person from whom you purchased it was involved in a larger organization, you were considered part of that whole conspiracy, that whole organization. So the war on drugs led to people who might get several years for a relatively small amount of drugs that they were selling, because they were now linked to a larger, what was considered to be almost like an organized crime operation, and you could get many years. And the federal government became involved in the war on drugs. So now there were greater resources to both prosecute and incarcerate people. Before the war on drugs, very few people were incarcerated in federal correctional institutions. And after the war on drugs and after the Get Tough on Crime wave was enacted, we saw people incarcerated at the federal level in far greater numbers than ever before and for far longer periods of time. The war on drugs has generally been seen as not very effective. Most studies showing drug use have seen it increase and decrease, but not significantly change because of the way we've approached the legal battle for drugs. And so it didn't necessarily curtail or reduce drug use. It may have changed some of it, but it didn't stop it. And there were also overtones of perhaps discrimination on which drugs were prosecuted to what extent. Crack cocaine being prosecuted at a much more strict, on a strict basis as compared to powder cocaine, and certain drugs perhaps being subject to larger sentences than other drugs based on the communities in which those drugs were being sold or used. The 1986 Anti-Drug Abuse Act established more severe penalties than even the initial phase of the war on drugs. And this led to many people who were nonviolent, who were not necessarily dangerous to the community, serving very lengthy prison sentences. And as we talked about before, if you have some untreated mental health conditions and you have substance use disorder treatment needs, and you now have a lengthy conviction, maybe even a federal conviction, and you have a lack of employment skills, and you're now leaving a lengthy prison sentence, finding employment and housing and continued treatment for your substance use needs can be very difficult. And many individuals caught up in that cycle, as we talked about before, had difficulty finding housing because now there might be restrictions on where they could live based on their drug conviction. They may not be able to live in certain places. They may not be entitled to some of the housing subsidies that are available to people with limited income. And many people who served long periods of time did nothing. And without assistance for housing and with being ineligible for some of the housing assistance that was available to other people, they were now struggling to find a place to live, to try and remain drug-free if they indeed had become drug-free while they're incarcerated. And at the same time, perhaps they had been separated from their family long enough that they didn't have the family support. So they were facing many, many obstacles to remaining in the community and remaining both in treatment and substance use disorder free. The Get Tough on Crime initiatives applied not just to substance use offenses. In the 1970s and continuing through programs such as the 1994 Crime Act, the sentences for offenders became longer and rates of incarceration increased significantly. This led to the United States becoming the country with the highest rate of incarceration in the world. We, to this day, still incarcerate more people than any other country. And the studies that I have seen still have us on a per capita basis incarcerating more people than any other country in the world. We tend to build a lot of jails and prisons. We tend to keep people there longer, and we tend to put people in for offenses that other countries may not lead to their incarceration. And the Get Tough on Crime initiative has eased over recent years, but the legacy of it still continues, and we still do incarcerate millions of people each year. And so the Get Tough on Crime initiatives led to not just the war on drugs, but other crimes now subjecting people to lengthy sentences. And actually, a lot of judges in the 80s and 90s and early 2000s felt very much like their hands were tied when it came to individual terms of justice, that if they had someone who perhaps had not represented a danger to the community, had shown that they were remorseful, had committed not many previous offenses, there might be some judicial discretion in the past, but now with mandatory minimums and very strict sentencing guidelines, many judges actually left their judgeships because they didn't have discretion. They didn't have any kind of judicial initiative to show discretion on what kind of sentence might be appropriate for a particular individual. And so the Get Tough on Crime initiatives led to our country incarcerating many, many people for a long period of time and then facing those obstacles we've talked about before. It's not all bad news. There were efforts along the way, and there are continuing efforts to try and help us reduce the incarceration of people overall, and especially people with significant mental health needs. Some of the initiatives started with drug courts, and in Miami-Dade County, which was one of the hotspots for drug distribution, in 1989, there was the first drug court. And the intent of a drug court model is to be significantly different from a standard criminal justice model. The intent is supposed to be non-adversarial, meaning that people are getting together to do what's best for the individual who is proceeding through the drug court process. And they use a multidisciplinary approach, meaning there is law enforcement representation, but there are also social services and substance use treatment professionals who are looking at developing an intervention rather than an incarceration. It's a great concept, and it has been used throughout the country. There are many drug courts in the country right now that are still operating. It has had success among many people who otherwise would have been incarcerated for lengthy periods of time. And the National Institute of Justice has estimated that drug courts adhere to a model that involves things like offender screening and assessment of risks, needs, and responsivity. So you're screening someone and you're looking at the risks both that they pose, but the risks that are posed to them by their behavior. What specific needs they have. Two people appearing in drug court may have very different needs. One may have a very strong need for educational support if it's someone with an inadequate educational history. Someone else, the needs may be more severe for their substance use disorder. Someone else, the needs may be more about social support or about occupational or housing support. Responsivity is a phrase that's been used a lot in the criminal justice world to describe the way that we intervene with people. Many people have similar problems but have different responses to interventions. For some people, the responsivity approach would mean that you're looking at perhaps their educational or their intellectual level and to know what kinds of programs would be appropriate for them based on how well they can cognitively process what is happening. For some people, perhaps the substance use is a response to underlying mental health conditions. And what you need to treat first and foremost would be the underlying mental health conditions, and the substance use disorder perhaps can be treated subsequent to that. For some people, there isn't an underlying mental health condition, but you're focusing more on relapse prevention because most of what they're doing is social and drug culture oriented. Responsivity is about making things individualized and making them hopefully based on input from the individual who is receiving the interventions. Judicial interaction, meaning that it's a two-way process. And of course, there's monitoring and supervision. We want to make sure if someone is in a drug court that the program is working, because a lack of incarceration for someone doesn't necessarily mean that they're going to thrive. If someone's continuing to have substance use problems and we're not tracking them, we're not monitoring them to see if they're able to function, there's a risk that they may not be able to survive or function in the community. There are graduated sanctions and incentives. Having worked in many county jails, I've talked to many people who have not been able to comply with the conditions of the drug court and have ended up incarcerated. And some of them are highly motivated to get back into treatment. Some of them feel discouraged. And I think when we see these graduated sanctions and incentives, we have to remember that it's a double-edged sword. It may motivate some people, but other people may get caught up in that cycle of a lack of self-confidence or feeling that they can overcome their addiction, underlying untreated mental health conditions, or perhaps social, economic, or housing conditions that are not being fully addressed. So while the graduated sanctions in some sense make sense from a criminal justice standpoint, from a treatment standpoint, we look to try and understand the cause of someone's behavior and look at their motivation and look at their goals to see what are we missing, what can we as treatment providers do better. The criminal justice system in terms of the drug court is a mixture of both criminal justice and treatment approaches, and sometimes if someone is not compliant or is not showing up, the criminal justice end starts to take the lead. And of course, there are treatment and rehabilitation services, and rehabilitation is a very curious word because rehabilitation means typically to bring to a former state. So sometimes you have to think about at what point did the person function well and what were the strengths prior to their substance use disorder problems, or the things that you're starting from scratch. Maybe they've never held steady employment. Maybe they've never had good housing. Maybe they've never really fully engaged in mental health treatment. So the diversion models, a lot of them started with drug courts. There are approximately 2,400 drug courts in the United States at this time, but it's estimated that if drug courts were really available, then we would have perhaps 10 times as many individuals going through as go through now, because the vast majority of people in our criminal justice system, due to the war on drugs and get tough on crime laws, has exploded to the point where the vast majority of people are there because they're in some way affected by substance use. And this was not the case prior to the war on drugs. Most people that were incarcerated were there due to your standard crimes, not due to substance use problems. Mental health courts were developed as a corollary to substance use or drug courts, and they had similar intent. The intent was to treat people in a non-adversarial way and to find treatment for people where the motivation or the influence on the behavior was not necessarily criminal intent, but was based on some mental health problems they might be having or some social service lacks that they were experiencing. And there's been a lot more controversy about mental health courts because while sanctions for people that are abusing drugs were seen as kind of a logical progression for people not being compliant with drug courts, concern about mental health courts is some people may not fully comprehend or may have difficulty complying with what's being recommended through the mental health courts. And if there are sanctions or if there is incarceration, it looks like there's punishment for having a mental health disorder. And some people feel that that's a criminalization of mental illness. Some of the courts, the mission is not nearly as clear and the treatment's not as available as we'd like it to be. And so it becomes a challenge for people to administer and implement mental health courts. As a result, there were far fewer. There are estimates between 150 and 300 of these mental health courts in total in the United States. In the state of New Jersey, for example, there are no mental health courts that are functioning at this time. If you're interested in both mental health and drug courts, you can certainly do your research. The mental health courts, an easy place to find locations of those courts is through SAMHSA, which has two websites that are up on the screen right now. And it will locate in every state both adult and juvenile mental health courts if they do indeed exist. Mental health courts kind of went hand in hand at one point with a move towards mandatory outpatient care, where some states were trying to use a diversion model that instead of incarcerating individuals, people would force them, one way or another, to be in treatment. So they would not get incarcerated, which is a good thing. But the application of forced treatment raises a lot of issues. What is the consequence of lack of compliance? How do you handle issues such as medication when someone is refusing medication? Do you make that a condition of remaining in the community? And given that there are side effects or some people have strong beliefs about medication, you may be setting up a situation where people are getting treatment against their will, and that does not typically go with the mental health treatment model that we would offer in the community in general. So the diversion models have some very good intentions, but as you get into coercing people into treatment or holding consequences over them if they don't comply with treatment, you get into issues of whether or not the treatment will be effective or if it follows what most of us consider to be mental health treatment choice for consumers. One of the other diversion models that I want to speak about is called the Crisis Intervention Team model. And this was developed initially in Memphis, Tennessee. Some people call it the Memphis model. What happened in 1987 is police officers were responding in Memphis to a call in which a young man was reported to be threatening people with a knife. The officers who responded, of course, at that time, the standard procedure was to take command of the situation. Police officers have a very important responsibility to keep people safe. And in 1987, when they showed up, they were not trained to deal with things from a mental health perspective. They were trained to deal with public safety. And so their initial response was to order this person to relinquish the knife. And when he refused to do so, they shot and killed him. The mayor of Memphis was then left with a very difficult problem because from a police officer standpoint, he had two officers respond to a scene with someone who was seen as dangerous, who could be dangerous to the police officers or the community. And if the mayor did not back his police officers, he risked that he would lose the support of the police force. However, the community was understandably very upset because they had called for intervention and help, and they ended up with a member of their community being shot. So what the mayor did is the mayor created a coalition, a partnership, and NAMI was a key member of that partnership. Clergy were involved, business leaders, the University of Memphis offered some mental health professionals, and this team came up with the Crisis Intervention Team model. It's a model that's been replicated in many states. We here in New Jersey have replicated it in several communities, many communities, and we actually, the people that brought it here to New Jersey went and trained with the people in Memphis who developed the model. The idea for this diversion model, unlike drug courts or mental health courts, is to divert people before there's any court proceedings, before there's any arrest or booking or any criminal justice intervention along those lines. And the Memphis CIT model, one of the catchphrases is it's not just training, but it does involve specially trained officers. One of the firm beliefs is that not every officer necessarily is well suited to become a CIT officer. The CIT officer needs a special set of skills. Those skills involve using de-escalation techniques, having strong interest in helping people solve problems, not just taking control of a situation. understanding that how people present may not always be what their intent is. So some people who are non-compliant with commands may be non-compliant not because they're threatening your authority or because they represent a danger, but they may not comprehend the commands, or they may be responding to internal stimuli, to hearing voices, or they may have had several very difficult and unfavorable outcomes in the past where they've been mistreated by people in authority that they feel they're protecting themselves. The de-escalation techniques are used to try and understand what's happening, to try and diffuse the situation so it doesn't become more violent, and to offer someone the hope that they can get treatment instead of incarceration. A lot of what will make a CIT program in any community successful would be linkages to treatment facilities. And if we go back to the original Community Mental Health Centers Act and the shortcomings there, one of the shortcomings that we have to struggle with the CIT model is a lot of officers with very good intention find that getting treatment for some of these individuals is a lot easier said than done. Sometimes some of the individuals have um, worn out their welcome at certain treatment facilities. Sometimes there are waiting lists. Sometimes there are transportation issues. Sometimes there are just not adequately trained professionals in the community to help the person. And so these linkages often take time, often take people becoming familiar with the mental health community and the mental health community becoming more receptive to treating people who may have had criminal justice involvement. A key part of the CIT model is not just training police officers, but making sure you have mental health professionals who are trained to understand how this works. And in many cases, the teams will involve mental health professionals going out on the CIT calls. It also involves training dispatchers so they can help identify what's a CIT call, when do you send out a CIT team, and when do you send out just a standard police personnel to deal with the situation. Because some situations do call for standard police intervention, and some situations call for CIT interventions, and knowing the difference between the two is very important. At this time, there are over 2,700 CIT programs throughout the United States, and we have many of them here in New Jersey, and we find them to be successful. However, it takes maintenance. Part of the easy aspect of this is the enthusiasm when we first start to develop a CIT program in a local community. Typically, people like the model. They're very actively supportive of implementing it, but you have to take the time to train people, to build those linkages between mental health and law enforcement personnel, but then to sustain it because times change. The standard of care in the community may change. The officers may change, and new officers may need to be trained and incorporated into the team. And certainly programs change. And so what an officer knows is available one year may not be available the next year when that officer is trying to get someone connected with treatment. I have seen communities where they have provided tablets to members in the community, consumers of mental health services, who, when they're in crisis, can, through a tablet, do a telemedicine visit with someone on the spot. And this way, if an officer is called to a scene and this consumer has a tablet and they're able to connect with a mental health professional rather than being taken to a crisis screening center out of their community, they may be able to get treatment on the spot for their particular crisis at that moment. So what can you do? We've talked about the history. A lot of the history feels very large and imposing. Things like Mental Health Centers Act, things like war on drugs or get tough on crime, state hospitals closing and not having sufficient amount of treatment. All those things can feel intimidating, but most change takes place locally. The first thing people can do if they have interest in this is you can educate yourself about the criminal justice system. Learn about your state, local, and national initiatives. Learn what programs are available in your community. Learn what's available elsewhere and bring it to local politicians, to community leaders, to your mental health treatment centers, to law enforcement. NAMI has a wonderful initiative called the Stepping Up Initiative, which is all about this tremendously high rate of incarceration of people with mental illnesses. It is true that people with mental illness tend to become incarcerated more frequently and stay longer than people without mental health diagnoses. And the number of people that are incarcerated is staggering alone in the United States. But then the number of people who are incarcerated and have significant mental health issues is even higher. And the percentage of people who are incarcerated with mental health issues is much higher than that of the standard community. Learn more about the CIT Crisis Intervention Team chapters in your area. If there's one in your community, great. Find out how you can be supportive, be involved. If there's not one, talk to the district attorney or to the local NAMI head, or talk to the mayor, talk to the police chief, talk to anyone who will listen and ask if they've heard of CIT, ask if they think that's something that you could help them start to initiate. Talk to those decision makers in your community, because this is where change happens. It happens locally. And if you voice your concern at the local level, some of the large scale incarceration efforts might start to change, and perhaps the efforts go into providing treatment. Having worked in many jails and prisons over the years, I've seen so many people incarcerated who clearly were not dangerous, but had committed what is technically a crime, and their mental health treatment needs were way underserved, because you typically have a very low ratio of mental health professionals to incarcerated individuals. And most of what is done in jails and prisons is to help people deal with crises first, to help the facility function, help people not take their lives if they're feeling suicidal. There's a lot of emphasis on identifying people at risk for suicide, at risk for danger to others. And when you get past all of that, the resources that are available for long-term mental health care treatment is not the level that we clearly need. And the basics for this would be to ensure that we incarcerate far fewer people who are not dangerous and have mental health treatment needs. That is the information I wanted to present. I am going to stop sharing my screen now. I do want to leave it open for any questions that people might have at this point. So with that in mind, if there are questions, I certainly would be interested in responding to them. Anybody? I don't see anything popping up on my screen. Let me pull up the chat. It says the chat is closed. Can I open the chat? Q&A. I'm not creating questions yet. Well, I'm not going to create any questions. I'll see if people have any questions, if they're able to do so. I did end a few minutes early for the chat, so if people do want to, I do see is Q&A. So someone asked about what Center for Family Guidance does. That is a good question. There are a lot of affiliated organizations, sister companies, if you will, that comprise CFG Health Systems or CFG Health Network. Center for Family Guidance is an outpatient mental health treatment center. We function somewhat like a private practice in that we don't have large scale treatment teams. We don't have a lot of bureaucracy. We provide treatment to people in our community. We have 3 offices, but we're part of a larger organization that provides services to people, residential services for adolescents, partial care programs for children and adolescents. We serve a lot of the hospitals here, providing mental health treatment services and consults to people in general medical floors around here. So we do a lot of things. In terms of Center for Family Guidance itself, if you go to our website, Center for Family Guidance in Marlton, you'll see our 3 offices, and you can see all of our clinicians. The status of involuntary outpatient commitment law. It was something that was starting to happen in New Jersey. I don't know the current status, but it never came to fruition. Some of the questions surrounding it had to do with what happens when there's non-compliance, what happens when there's inadequate resources, and how do you monitor it. So New Jersey, it's never become functional. Other states have done that. And again, it's controversial because in some cases you end up prosecuting someone for not being compliant with treatment, and what kind of sanctions or disincentives do you hold over them if they don't comply with treatment? And that has made it difficult. Some people are in favor of it as a first-line intervention instead of incarceration, and there are merits to that. But again, you have to think through the ethical and practical effects if someone is not compliant. Any other questions? Well, I am going to share my screen once more. Hang on one second, because I do want to put up my contact information. I wanted to make sure that why does New Jersey not have mental health courts? That is a good question. Goes beyond my scope. I think one of the main concerns people have had with mental health courts, and I'm not saying I agree with this, but one of the main concerns is people believe that individuals will feign some kind of crisis or mental health problem so they can avoid um, any kind of criminal justice sanctions. Mental health courts in general have been, as I said before, far less common than drug courts. You can test for substance use. You can run a toxicology screen to see if someone has abused a substance or has used a substance. It's hard to screen to see if someone's compliant or not compliant with mental health treatment. So that is one of the reasons why some people are reluctant to embrace mental health courts. CIT, in some ways, has a similar approach to mental health courts in that the intent is not to prosecute people, but to have people get treatment rather than incarceration. So in some ways, CIT, I wouldn't call it a substitute for mental health courts. It's a precursor to it that can have people who have mental health treatment needs not become involved in the court system at all. And mental health courts, it's not just New Jersey. If you go on that SAMHSA site, you'll see that many states have no mental health courts at all. And that's political as much as it is anything else. I am pulling up my contact information. I'll wait for another question or two, and then it will be time for us to close out. So if there are other questions, I would certainly answer them now. If not, I'll just put up my contact information, and hope you enjoy the rest of your presentations. So let me pull that up. So you should see right now my email address. It is jfriedman@cfgpc.com. If you want to take note of that, I certainly would like to hear from any of you that have follow-up questions, want to learn more about CFG, but more importantly, more about these issues. I also happen to teach a class at Rowan called Treatment of the Offender, which is something I've been doing for many years. And that course addresses these specific issues. What happens when people with mental health treatment needs become involved in the criminal justice system? And we could obviously go into a lot more detail than I can in 40 or 45 minutes with the multitude of issues that come with assessing and providing treatment for, and then post-incarceration, both supervision and treatment for people with mental health treatment needs. Again, I thank you for your time, for your interest in this topic, and feel free to contact me if you have any further questions. Hope you all have a good night.